Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me for a dislocated IOL. This patient had a dislocated lens implant. It's actually a plate haptic style lens implant. And so I'm going to show you how I explant this lens and how I do my modified Yamane technique to exchange and replace it with the C2 Lucia 602 lens. One of the important things with IOL dislocation and replacement is knowing the lens implant you're removing. And so this is going to be part of that discussion. You can see this patient has a dislocated lens in the bag lens, and it's a plate haptic lens. I wasn't quite sure if it was that style lens until I actually got into the eye doing the surgery. You can see it's quite unstable and jiggling in the posterior segment. I'm using a cotton tip to dry the surface of the conjunctiva, and using the tip of a 27 gauge cannula, I'm going to go ahead and mark the limbus with the ink pen right at the limbus at that point, and then making sure it's dry, and then performing the same maneuver on the other side, making sure I'm 180 degrees apart. And I'm using the cannula as a gauge to find the 180 degree axis on the other side contralateral to that first mark. I'm using the cotton tip to steady my cannula as I do that maneuver there. And so it's easy when you're trying to go at the eye kind of without support to have a little bit of a shake. And so that's kind of my tip. I'm going to go have 2.5 millimeters posterior to the limbus there. I'm setting the caliper, and I'm going to go straight back from that mark, indenting the sclera. And mind you, I haven't entered the eye, I haven't made any incisions yet, and so that's why the eye is nice and firm here. So we'll get 2.5 millimeters posterior and then 2 millimeters adjacent to that spot in a right angle. And you can notice that the eye is in the neutral position. I'm not rotating or pulling on the eye. When you do that, it actually can change the anatomical position of your conjunctival mark, and it might not actually be 2.5 millimeters posterior to the limbus. And of course, if the marks don't reflect where you want it to be, you can have a malpositioned lens once you fixate it to the sclera. So again, 2.5 millimeters back and then 2 millimeters adjacent. So now this is the trocar. I'm going to indent, and you can see it and mark the episclera there. I'm going to go about 3 millimeters next to it, puncture, and I'm going to tunnel through the sclera towards that mark, which is about 4 millimeters back. And then I'm going to rotate perpendicular, and then I'm going to push, and then it enters. And you know that's a good shelf because the trocar is sideways there. So I make my incisions now with my diamond blade. That was for my AC maintainer. And these incisions are to help me with the actual explantation and surgery. This incision is contralateral to my main incision, which is going to be the incision to externalize a leading haptic from my modified Yamane technique. This is intracameral lidocaine and epinephrine. You can see how much the lens is wobbling with that fluid. And then this is some dispersive viscoelastic to coat the corneal endothelium. You don't want to push too much viscoelastic, which will push the lens back even further. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove using the cannula to hold the eye. I tunnel and then enter. These are just some more paracentesis incisions. I'm going to go through the trocar to get to the lens, but as you can tell, the lens has moved back even further in the vitreous space. And so what do you do in this situation? Well, there's viscoelastic that is a barrier now, and that's part of the reason why the lens has gone backward. And so I'm going to go in, and in front of the lens at the iris plane, I'm going to do a vitrectomy. And so I'm going to move at 4x speed because this just takes a little bit of time. But as I remove the viscoelastic at the iris plane and underneath the iris plane, you can see that the lens is starting to come up now. So now that it's up, I'm able to go in through my trocar there and lift the lens with the cannula. I'm going to go in with microforceps to retrieve the edge of the lens So you can see that's the plate haptic. I'm grabbing it by the edge of the haptic there, and then I'm going to quickly transition to another microforceps to secure the lens. And then I'm going to sweep underneath the iris to prolapse that lens up as much as I can here. The lens is actually quite slippery, and so it's very important that you don't lose the lens as you do this maneuver. And so I get a nice, big, hefty bite and grip with my left hand. And I'm going to start to cut the lens in half lengthwise. So again, this is a plate style lens. I'm grasping it and cutting it lengthwise. While the scissors have the lens, you can actually re-grab with the left hand, and that's what you saw me do right there. You don't want to cut all the way through, because if you do, you might lose the second half of the lens. So as I'm holding the lens with the left hand, I'm going to retrieve the lens in the main incision with my right hand. And because this lens is very soft and malleable, as I pull out the first half, the second half just kind of flipped over into the vitreous space. And as it flipped over, I was able to grasp it and then pull it out. And so again, knowing the type of lens you have is really important when you're doing lens exchanges. That lens material is very, very soft and malleable. So I knew the explantation would be quite easy and fairly atraumatic to the eye. You saw I burped some of that Summerings ring, which came out quite nicely there. I'm placing my 20 gauge Lucia AC maintainer, and then I'm doing a really nice anterior vitrectomy. This is an 8x speed. Again, just to simply reiterate that I'm spending a lot of time doing my vitrectomy, making sure there's no vitreous anywhere I'm going to be manipulating for that secondary lens placement for the modified Yamane technique. So I'm placing my microforceps through the contralateral incision, placing the injector in. My assistant is advancing the lens, and as she does so, I'm going to grasp the end of the haptic, externalize the haptic, ask her to stop, and then I'm going to take over and start to deliver the optic, making sure that the optic comes out in the correct orientation. And then I'm going to sweep that haptic, trailing haptic to the right so that the optic comes out correctly. I inject some more viscoelastic to push the optic back and to protect the corneal endothelium. And this is a right side needle. I'm going to bend it about 9 to 10 millimeters from the tip. Again, the bevel is facing me. I'm going to place the trailing haptic in a U-shaped configuration for me, which will be an easy grab and go technique there. I'm moving the AC maintainer out of the way for me, trying to maintain the neutral position of the conjunctiva. I tunnel through the mark, tunneling 2 millimeters, and then turning straight towards the optic nerve, and you enter. You want to make sure you go towards the optic nerve, because if you go more parallel to the iris plane, you might hit the ciliary body. And then grasping the microforceps at the apex of the U of the trailing haptic, you grasp it, dock it on the bevel of the needle, straighten it out, and then gently advance it, which goes in quite easily here. So I'm using a hemostat to disengage the syringe from the needle and make sure it goes in to the proper position into the posterior space. With microforceps, I'm going to pull the leading haptic into the eye, making sure it's in the angle there. And with this needle, you want to make sure the bevel is facing away from me, and that will be facing the approach of the leading haptic. Holding the eye in the neutral position, I'm going to tunnel with the needle, go 2 millimeters, and then dive straight back towards the optic nerve. Again, by going straight back, you're going to be able to minimize hitting the ciliary body and cause a hemorrhage. Using microforceps, I'm going to grasp the leading haptic, dock it on the bevel of the needle, flatten it out, straighten it out, and then you can cannulate it very easily. With this one, you don't have to go in too far, and because I'm going to be pulling it out right now. So as I pull out, I'm able to retrieve it, hold it with the forceps, make sure it's not too externalized, and then create a small bulb with a cautery. You can see there's some ballooning of the conj from the infusion, which is okay. As I pull the needle out, I make sure that I retrieve the haptic so it doesn't go back into the eye, and then I go ahead and cauterize the tip in similar fashion. And so that's why it's so important to make sure you mark and do all the maneuvers and get it in the first try, because if you're not doing it right, you can get all this ballooning, and it's really going to affect your landmarks, your anatomical landmarks in your orientation. So you push the haptic flush to the sclera. By doing it this way, it'll minimize any potential for extrusion. And this is the surgical PI, the vitrector assisted PI. I'm going temporally, facing the vitrector, the cutter down against the iris. You can see I'm able to increase the vacuum and achieve some level of aspiration, and then I go further down and it starts to cut at a very fixed rate. It's a very controlled way to do the vitrector PI. It ends up being a really nice peripheral small PI without it being too large. And this is some intracameral Kenalog. I'm just going to put some of that triamcinolone into the eye to see if there's anything there, any vitreous strands. I'm going to first go through the limbal incision and do an anterior vitrectomy at a high cut rate, just in case there's some vitreous there. Most of that stuff went posteriorly, so I'm going to go through the trocar and then start to cut, making sure I can see the cutter through the pupil. And as I do this, you can see that the view continues to gradually improve, and you can see less and less of that triamcinolone. More importantly, there's no obvious vitreous in the anterior chamber that I can see here. And the pupil is nice and round. So instead of switching to INA, I go ahead and use the vitrector and switch to cortex mode. And so there's no cutting here. It's just high vacuum and aspiration with a decent IOP. And so going around circumferentially and removing the viscoelastic from the anterior chamber. I grasp the trocar with forceps, and as I pull it out, I massage the sclera. And I'm pushing pressure on the sclera, and then also felt the intraocular pressure, which was nice and firm. I made sure to check the pressure with my finger, and it was nice and firm, which tells me that the sclerotomy is watertight. So I like to place a tendonolon suture at my incision, which I go ahead and do here, and then I will bury the knot. I don't want to have any potential vitreous come to the wound at the end of this type of case. So I take the AC maintainer out, and then I'll hydrate my incisions, and that's the end of the case. So again, this patient had a dislocated plate haptic lens. Thankfully, these plate haptic lenses tend to be dislocated within the bag, and the haptic is fairly easy to grab, but it's a little bit slippery, so you have to have a really nice grip when you cut the lens. Thankfully, it's quite malleable and flexible, and so when you cut it, you're able to manipulate it fairly easily. It's kind of like, manipulating an ICL. It's a very soft and flexible material. In contrast, some other lens materials, obviously a PMMA lens, you can't cut. And so it's very important to know what kind of lens you're dealing with when you're doing an explantation. And if you know the type of lens implant, the better you can attack and have a plan on how you deal with it. Thankfully, the Summerings ring came out nicely, as well as the rest of the bag. And you saw my modified Yamane technique, externalizing the leading haptic, going after the trailing haptic, which makes it so much easier. I like to dock the bevel on the needle, make my conjunctival marks, making sure I hold the eye in the neutral position, which makes it for a very controlled and kind of easy way to make sure that my conj marks match my intended scleral needle placement, which again gives me the best potential refractive result and also ensures that the lens is not going to be tilted or malpositioned, which reduces the risk for UGG syndrome and iritis and so forth. So I hope this was helpful to you, and I thank you for your attention.